So the next professor is Dr. David Biko. David, good afternoon. I am very happy to have you here.
Yeah, thank you so much for having me.
So David is a professor, is a pediatric radiology, and he works at the Children's Hospital of Philadelphia. He's member of the SPR, and also he's member of the Radiology Society of North American Society of Cardiovascular Imaging, and Society of Cardiovascular Magnetic Resonance. He also is a very known research and a great friend. So thank you so much, David. It's a pleasure to have you here. And also it's very important to have your lecture because there is an increased number in our hospital of Fontan procedures, and it's very important to know about it.
Thank you so much, Carlos. Yeah, I feel the same. Thank you for inviting me, and I'm very happy to be here. It's my topic. It's the thoracic complications of the Fontan procedure. So just a brief outline of what I'm going to talk about today. I'm going to just do a brief review on single ventricle Fontan palliation, but really I'm going to get mostly into the imaging of the post-operative Fontan and predictors of outcomes. Much of this is going to really concentrate on cardiac MRI, as that's been our main tool for Fontan palliation evaluation. So first, just a brief background for some. I know many may already know this, but what is a single ventricle? It's really when there's only one effective pumping chamber, maybe functional or anatomical. And these single ventricles come in all different shapes and sizes. Tricuspid atresia was the first Fontan palliation was done on tricuspid atresia, but any different, when there's an inadequate pumping chamber, inadequate ventricle, those will be classified as a single ventricle and go on to Fontan palliation or total cavopulmonary anastomosis. And this occurs when a two ventricle repair is not possible. So just to show you kind of one of the classics we always think of in single ventricle is hypoplastic left heart syndrome. So here's our normal heart. But here is our hypoplastic left heart, where we have this small arch that comes up here, and we have a small left ventricle. So as you can see, that the blood is going to be supplying the systemic circulation here through the PDA. And as Dr. Eppelman just talked a lot about PDAs, I think this ties very nicely. So you have that PDA here, which supplies the systemic circulation from the PA circulation in hypoplastic left heart syndrome. So there's a systemic circulation obstruction. Hypoplastic left heart comes in different, different variable degrees. You could have a hypoplastic LV, even to a hypoplastic mitral valve, aortic valve, proximal aorta, or left atrium. And again, there's systemic perfusion of the aorta entirely through the PDA. So Fontan palliation, the kind of the Norwood procedure, specifically when we're thinking about a hypoplastic left heart, first we start with the reconstructed aortic arch. There's homograph material placed here, and this is a Sano shunt, but you also could have a Blalock-Taussig shunt going from this is from the RV to the PAs, so you continue that systemic supply of the PAs, or you can have a BT shunt, which will be going from usually the right subclavian artery to the right pulmonary artery. Then at about 4 or 5 months of age, they move on to a bidirectional Glenn, which is a superior cavopulmonary anastomosis, as you can see here, where now the Sano shunt or BT shunt is taken down. You still have this reconstructed arch, and then we have passive flow from the upper extremities and head to the pulmonary arteries. And then finally, the Fontan palliation, right, is a total cavopulmonary anastomosis. This bidirectional Glenn is left in place, and then there is a Fontan pathway brought from the inferior vena cava up to the RPA. So just to show you briefly, here's an example of a Sano shunt, where you see this is a black blood MRI. We have this shunt here. And you can see there's that this is the kind of hypertrophied RV and the supply to the PAs in this patient, the first step onto Fontan palliation. Here's stage 2. So I'll pause it here. We can see there's this Glenn anastomosis where the right superior vena, the superior vena cava attaches to the PAs in this patient with stage 2. So there are different kinds of Fontan palliations. The oldest surgery is the atriopulmonary, where the atrium is kind of hooked up directly to the PAs. But more commonly now, we're doing lateral wall tunnel Fontans, where the conduit is kind of tunneled through the atrium, and then an extracardiac Fontan, which is it's the easiest one to really understand, as you can see that Fontan pathway come up, and can be with or without a small fenestration, which is a little hole to the atrium. So first question, when you think about outcomes, really, like, does the type of Fontan matter? And it does if you have an aortopulmonary Fontan. So you can see here the aortopulmonary Fontan, or atriopulmonary Fontan. Sorry, that is a typo. The atriopulmonary Fontan we have is the survival is less than the other Fontans. And as you can see, as we've gone through the years, right, the atriopulmonary Fontan is kind of done less, and we're seeing more of these extracardiac or lateral tunnel Fontans. So it does matter. You really don't want to have an atrio. This shouldn't be atriopulmonary Fontan. Moving on to complications, and we think about complications within the chest, right? These are our things we're looking at: the lymphatics, the lungs, and the heart, right? These are the things that will complicate the chest lymphatics through either, plastic bronchitis or chylothorax. The lungs, remember, there's pulmonary vascular remodeling, and there's that pulmonary vascular resistance. And one of the troubles with Fontan, right, is the increased pulmonary vascular resistance. And as you have that passive flow of blood to the PAs, you don't have a pump in there to pump to your lungs. So if you have increased pulmonary vascular resistance, you're obviously going to get less blood flow to the lungs. To the heart, arrhythmias are common, and they cause hemodynamic instability. So what are our imaging tools? Well, echocardiography, is the most commonly done in cardiac imaging. It's sort of the mainstay. As ultrasound is to us pediatric radiologists. But we also have cardiac CTA and then cardiac MRI, which is really our key tool for evaluation. So can echocardiography predict outcomes? Well, it can. When we look at a failing Fontan, we think of it as survival or transplant or death. So if you have moderate systolic dysfunction or global circumferential strain abnormality or reduced ejection fraction, you have poor outcomes on echocardiography. But if you combine that with the end diastolic volume from MRI, you can see this curve. Here's our global circumferential strain curve, which goes down when it gets poorly. But all this goes down significantly when you combine it with the end diastolic volume, high end diastolic volume, indexed end diastolic volume, and global circumferential strain on echocardiography. Moving on to CT. CT is used really for anatomic evaluation due to its high spatial resolution. It helps with stents where MRI may have difficulty, and of course the lung parenchyma. The disadvantages are the temporal resolution is lower than the MRI for volumetry, and we're unable to quantify flow, which I'm going to show you later has some key metrics when it comes to Fontans and outcomes. So why do we do it at CHOP? We do it for anatomic assessment. So conduit complications such as thrombosis or stenosis of either the Fontan conduit or the superior cava pulmonary anastomosis. We often do it for pulmonary venous stenosis, as those patients will have stents and they won't go to cardiac MRI for an anatomic evaluation. And then, of course, when cardiac MRI is contraindicated or there's an artifact within the heart that we're not able to get an MRI to determine ventricular volumes, we'll do those on CT. And then finally, if there is a question about lung parenchyma, we'll do those with CTA. When you're imaging a Fontan patient with CT, the rate and timing it can be challenging. So we don't get that really nice pulmonary pathway, or a pacification of the pulmonary arteries like we would in a normal two ventricle heart. The IVC flow preferentially flows to the LPA, while the SVC preferentially flows to the RPA. So there's a difference in timing, and which makes this challenging, especially if you're trying to look at this conduit and looking at the pulmonary arteries. So there's two approaches for this evaluation. One is a dual upper and lower extremity injection, where you do 2 intravenous lines. One is the antecubital, one is in the dorsal foot. 60% of the contrast goes to the lower extremity, and 2 scans are performed, one at the PAs at the first set of contrast in the LPA, and then one at the inferior Fontan pathway, 60 to 90 seconds after the first scan. I don't do them this way. This is described, and I think most people do not do this dual energy injection because it is complicated, and you still need to get your timing correct. What I do is a single injection, an upper extremity line. I usually give the contrast at about 2 mLs per second. And then the scanning is really variable. I put in a huge range here, 70 to 100 seconds. I mean, even there's some papers out there that say 60. We tend to be probably in the middle there somewhere, 80 or 90, but we'll adjust it depending on the cardiac function, especially if there is a large amount of AV valve insufficiency. So here's an example. This case was done a little different. This is a 4-year-old hypoplastic left heart who had included innominate artery status post-Fontan, but he has atresia of the glen anastomosis. So here I was triggering off the single ventricle, or the dominant right ventricle, and I saw the Fontan pathway light up really bright. So I said, we should just scan. And this patient has got a very nice study. You can see the going down the SVC where there's atresia. So the flow is going down the azygos vein, and I'm getting nice opacification of that Fontan pathway in this patient. You can see the small fenestration also right there is a small fenestration. So this, because of the atresia of that superior cave of pulmonary anastomosis, actually was able to get really dense opacification of the Fontan pathway. Finally, moving on to cardiac MRI. This is really the gold standard for evaluation of the Fontan. We can do a lot with it, including anatomy, just as we can on CT for 3D printing and modeling. We could look at ventricular size and performance, AV valve insufficiency, and importantly, right, quantification of flows. And we'll talk about the fenestration flow and the AP collateral flow. Then we can evaluate myocardial scarring, and we can also evaluate the lymphatics. So for ventricular size and performance, we really do standard SSFP imaging. We do a 4-chamber Cine SSFP, a 2-chamber Cine SSFP, and then a short axis stack through the ventricle. And from there, you can see the contours, the epicardial and endocardial contours here on the heart to obtain the ejection fraction along with the myocardial mass and diastolic volumes. So why is this important? Well, ventricular size is important. First, I'm going to talk a little bit more about ventricular function, but ventricular size is important as indexed end diastolic volume on cardiac MRI is a predictor of death and transplant in patients late after Fontan palliation. And you can see here we have 125 mLs indexed per body surface area. And you can see how the time from Fontan, how the risk of death increases. Also included here is protein losing enteropathy, and I'm going to talk a little bit more about that, not specifically, as I know you're getting a lymphatics talk tomorrow, but just touch on that and how it relates to the Fontan. Additionally, you can see here on this other paper, this was out of the Boston group. The first paper was from Boston also. At a 10-year follow-up, there is a decline in indexed end diastolic volume, end systolic volume mass to volume ratio, ejection fraction, and end systolic wall shear stress. So if you have a faster increase in the end diastolic volume, you're going to have a more likely to have death or transplant. So these volume metrics are important metrics, specifically if you have increased end diastolic volume over time. Next, this is also out of the Boston group who have done a lot of work on Fontan. They kind of came up with a single ventricle global function index. They looked at 298 patients, and you can see the formula here. It involves end diastolic volume, end systolic volume, ventricular mass, and the lower the single ventricle global function index is associated with Fontan failure. So they've showed this to be an important metric. And additionally, they had a subgroup of 113 patients, which also had exercise testing. And this index was also associated with decreased predicted percentage of VO2 max. Moving on to flows, we do our flows with velocity mapping, which involves a bipolar gradient applied to the direction of flow. These protons are moving at different field strengths. We're able to get a flow curve from as these protons move through the plane. And when we evaluate the Fontan, we do a lot of flows, right? We do aorta at the valve, we do the cava, we do the Fontan baffle, the branch pulmonary arteries, the descending aorta, the diaphragm, the pulmonary veins, and the inflow, which is a lot of work. And this is where something like 4D flow really comes into to help you an evaluation of the Fontan, as you could acquire all this in a single sequence. But why do we do it? Well, we do it for pulmonary blood flow distribution. We also do it for systemic pulmonary collateral flow, and then finally the fenestration flow. So as noted, right, the SVC flow tends to go to the RPA, the IVC flow goes to the LPA. So there is a significant relationship between PA cross-sectional area and flow, but one of the metrics of whether they want to try to stent one of the vessels, right, is knowing if there is significant asymmetric flow to each of the lungs in these patients. And with that, right, if you're getting too much, if you're not getting enough IVC flow to the other lung, you're also going to put yourself at risk for pulmonary AVMs. So keep that in mind if there's no flow to the from below to that lung. And remember, right, our branch PA flow is going to equal our SVC flow plus our high Fontan flow. Moving on to systemic to pulmonary collateral flow. This is calculated based on flow data, again, from velocity mapping. You can see all this dynamic angiogram. You can see all these collaterals kind of coming down. These are going to be both arterial collaterals and venous collaterals. How do we calculate that? Well, we do the aortic flow minus the caval flow. So what is coming out the aorta should be returning to the heart. If it doesn't return to the heart through the cava, right, we assume it's gone to the lungs. And similarly, right, we can look at the pulmonary venous return from the lungs, and that should be equivalent to the pulmonary arterial flow in a patient without collaterals. But the difference between that, the flow going to the lungs, if there's increased flow coming back from the lungs, we know we have systemic flow to those lungs. So we do this calculation simple. We hope they're the same number. They're always never exactly the same number, of course, but it's a way to double check our calculation. So why is systemic to pulmonary collateral flow important? Well, higher systemic to pulmonary collateral flow is associated with postoperative chest drain volume, chest drain duration, and duration of ICU stays. So if you have this higher flow, then you're more likely to have these complications. Often we'll do flows pre-Fontan, get the collateral flow, and the interventionalist may go in and embolize some of those collaterals to decrease the collateral flow burden before Fontan palliation. What about fenestrations? Well, fenestrations, they're a little more controversial. When you do a fenestration, you get a right to left atrial shunt, right? It's really, a pop-off valve kind of for that pressure that's going to the PAs. So you're going to get flow through that fenestration into that common atrium, or the atrium that's septated or has a septostomy, I'm sorry. Why fenestrate? Well, fenestrations have shown to decrease pleural effusions. They've shown to have shorter hospital stays and decrease additional procedures. Unfortunately, there has been a couple of papers that has shown a increased long-term rate of death, increased complications, and Fontan failure. So it is still somewhat controversial. I think we're seeing most of our patients do get fenestrations, though. The fenestration flow is affected by a balance of the pulmonary vascular resistance, which makes sense, right? That flow going to the lungs, and diastolic dysfunction. And using cardiac MRI, we can calculate those flows with velocity mapping by looking at the difference between the IVC flow here and the superior Fontan baffle flow, difference between the SVC and the IVC flow and the PA flow, because that should all be coming to it. And then finally, right, what's coming back to the common, the atrium should only be the pulmonary veins if you don't have a fenestration. And then if we look at that, what's coming out of that ventricle, comparing those, we can calculate the fenestrated flow. So higher fenestrated flow is associated with decreased oxygen saturation, increased pulmonary vascular resistance, and better ventricular diastolic function. There is no correlation with collateral flow with fenestrated flow. Moving on to the anatomic assessment, we always do a dynamic MR angiogram in order to look for first pass perfusion of lungs, and also to look for these AP collaterals, which are sometimes really nicely seen on the first pass angiogram. And then we do a high resolution inversion coverage gradient echo angiogram to get better resolution, better spatial resolution in these patients. So why do we do the gradient echo? Well, we can use it for detailed anatomic evaluation. I can use it to really take a better look at the pulmonary veins and the coronaries. It makes it more of a one-stop shop. And also we can use it for things such as 3D printing. Additionally, the power of MRI, right, is you can combine anatomy and flows. And this is what we don't really have with CT, is we can use computational fluid dynamics by looking at the anatomy, segmenting the anatomy, looking at the velocities and segmenting those, evaluating the flow and the structures, and looking at different virtual surgical options and doing computational analysis in these patients. So this is, one of the futures, especially when we have all this physiologic data with 4D flow. We can do things such as this, where we're just kind of planning the Fontan baffle. And here's that's the Fontan baffle as they kind of hook it up to the PAs. And you see how that's the Glen coming down, right? And then there's the Fontan baffle hooked up. And you can really go through this and try to do different orientations of the Fontan baffle and see if you can improve flow to the lungs. So combining that physiologic data with the anatomic data using computational fluid dynamics. And how did it perform? Well, it wasn't great in this short, small paper, but the one thing it did is obviously when they do the graft insertion, there was a little bit of offset from the prediction to the graft insertion, and the error within this correlated with the graft insertion. So in a small number of patients, but this is something that really is the future as far as surgical planning. The last thing I want to talk about regarding cardiac MRI and single ventricles is myocardial delayed enhancement and fibrosis. This myocardial delayed enhancement or fibrosis is associated with decreased systemic ventricular function and a high frequency of ventricular tachycardia. It is higher in single right ventricles as opposed to single left ventricles. So it is something to take a look about as far as outcomes. Lastly, the lymphatics, one of my favorite topics that I speak about often. I'm going to touch on these as I know you're going to get a full lecture tomorrow on lymphatics from Dr. Otero. We always run a T2 weighted, or some people call it a T2 weighted lymphangiogram, but really it's just a heavily weighted T2 sequence with each of our single ventricles. This is our sequence that we run, and things we're looking for when we run the sequence is dilatation of the thoracic duct, and then lymphatic congestion within either the lungs, the mediastinum, even in the mesentery. So what happens, and why is this important? Why are the lymphatics important with Fontan? Well, if you're at stage 1, right, where you have that SANO or you have that BT shunt, you've got normal flow. A lot of this flow comes from the liver. You've got normal flow to the liver back to the cisterna chyli and up to the left venous angle. But what happens when you hook up that glen? Now you've got the superior cava pulmonary anastomosis. You've got increased central venous pressure in the upper extremity and head. Well, you're going to still have similar flow to liver, but you're going to have higher pressures and possibly decreased return of lymph through the thoracic duct to the left venous angle. And then finally, at stage 3, right, the Fontan palliation, now the IVC is also hooked up. So you're going to get higher pressures below the diaphragm, higher pressures above the diaphragm. The central venous pressures are up, and you're going to get more flow. You're going to start third pacing more fluid due to those Starling forces, more flow through the duct, and then decreased return. And this can put you in lymphatic failure. So a couple examples of kind of extreme things that we can see on T2 weighted imaging. This is, again, not a dynamic contrast stance lymphangiogram. There's no needle placement. This is just T2 weighted imaging. We can see all this lymphatic congestion. We can see lymphoceles. We can look at fluid. We can see here a dilated thoracic duct. We get this kind of congestion, this spaghetti looking congestion here. Here's another dilated kind of truncated thoracic duct, although we see some here and another portion of it on that MIP. So these are the things that we'll be looking for on T2 weighted lymphangiography. So what we did is we looked at pre-Fontan patients and classified them 1 to 4 based on the T2 weighted imaging. So these are the Glens and the hemifontans. So the stage 2, not the ones that have the superior cava pulmonary anastomosis. We looked at 1. We had a little bit of congestion and maybe a dilated duct. 2, a little more. 3, there's the congestion within the mediastinum. And then 4, where there's really interstitial edema and mediastinal edema along with supraclavicular lymphatic congestion, and looking at that kind of as a continuum. And what we found is we classified type 1s and 2s together as there was no difference. 2% of them did not complete the Fontan, these types 1s and 2s, but over half of the types 4s did not complete the Fontan. And these type 4 patients with all that lymphatic congestion had greater than 3 times length of hospital stay after Fontan. And finally, transplant and death only occurred in patients with type 4. Recently, we looked at this a little more, and this is a paper that's in revision, looking at the Fontans, the type 3s and 4s. Post-Fontan, looking at the lymphatics on T2 weighted lymphangiography, they're seen to have a higher association with chylothorax, plastic bronchitis, and protein losing enteropathy. And if you remember back to that early slide, protein losing enteropathy has a significant effect on outcomes in these patients. This was 15 subjects that were type 3s and 4s. 80% of these had at least one event, including these prolonged effusions or readmission for recurrent infusions, needing lymphatic intervention, even transplant and death. But only 18% of the subjects with type 1 and 2s had similar events. And there was a significant difference between these two groups. So even after Fontan, we're seeing that this T2 lymphangiography is showing changes in outcomes. So in conclusion, right, imaging and thoracic complications of Fontan can be challenging. Echocardiography, CTA, and CMR are our tools, but CMR really is the gold standard for evaluation of the single ventricle. We can see anatomy, we can look at ventricular performance, we can look at scarring such as myocardial delayed enhancement, the AP collateral flow, and of course, don't forget about the lymphatic evaluation. Thank you very much for your attention. Happy to take any questions.
Thank you so much. We really appreciate this class. It was really very complete of to the approach for the diagnosis and the complication of the Fontan procedure. So I had some questions because this is a topic that is very interesting for me. Well, the first of all is a very basic question. Which is the correct age to do the Fontan procedure? Because we know that all these CHD are time dependent. It's very important to do the surgery in the right time. So which is the correct age for Fontan procedure in children?
And you know, that's a good question, and I may not be the best to answer that question, as I see the imaging. Unfortunately, yeah. what makes cardiac imaging fun also makes it challenging in the sense that all of these patients are slightly different. Like some have bad AV valve insufficiency, some have pulmonary vein stenosis, some have PA stenosis, So the age is when to complete the Fontan is really a challenge, right? I mean, they're usually, toddlers, but this is a discussion that we kind of have in our conference, our surgical conference, very commonly. Should we move to Fontan? Should we move to Fontan? Interesting enough, when I talked about the and I know I didn't really answer your question because I don't have an answer, unfortunately. But interesting enough, when we talk about the lymphatics, is if we see these patients with terrible lymphatics, they'll end up they'll end up trying to do the Fontan, but surgically doing a venous anastomosis to the left atrial appendage with that to try to decrease the pressure. So we do that at our institution. I don't think we have those patients are so far. We've done a few of them. So we don't have great data as far as whether it's working, and obviously long-term is going to be the, it's really the long-term outcomes is what's most important with those patients. But rather than waiting for them to go to lymphatic failure, they take the innominate vein and they'll anastomose it to the left atrial appendage to try to decrease those pressures. So in the end, I don't have an answer as far as the exact age. It's really dependent.
It's really dependent, and also, as you said, maybe the long term of huge data will give us the answers in the future. About the techniques to do the CTA, you show this 2 injection, but you said that you use just single injection as well. Most of we do this just single injection. In the single injection, you do a split bolus or just one bolus?
Well, it depends on what you're looking for. So, right, if you want to see if you want a nice aortic angiogram, then you would do a split bolus or 2 scans. But if you're just trying to see the Fontan pathway, if that's the question, we just do a single bolus and don't do a split bolus. We often will give 3 mLs per kilo in those patients. So we'll up the dose of contrast also.
Talk later. Great. I have another question about the. You showed these beautiful tables about the surveillance and the relationship of the SAD volume, which is the how long how many contrasts do you do after the Fontan procedure? Is there a specific time that you do you do the control the MRI year by year?
Yeah, so we're following these patients almost every year with an MRI in general, at least for the beginning. So we have gone many ways. We don't cath these patients as commonly unless there's a complication. So even pre-Fontan, we don't always cath them. They'll often just get an MRI and not have to go to cath. Some of these more complicated patients, we do both, but we're following them almost yearly in the beginning in the patients. And then after time, as they become adults, less frequently.
Okay.
But with serial
MRIs
and echoes.
Okay. Got it. So for fibrosis, there are also some role for T2 and T2 mapping, or just enough with the late gadolinium enhancement sequence.
Yeah, so we often do run T1 mapping on these patients. Unfortunately, we don't really have, we know the fibrosis has an effect. So theoretically, what is T1 mapping abnormalities is diffuse fibrosis. The question, the troubling thing, or the trouble with T1 mapping, right, is this single number and knowing, what is normal. So that's really the challenge with T1 mapping. So what ECV is normal? I mean, I think this is what we're struggling with in many things with children, is what is normal, as opposed to, using the adult data for just a normal 2 ventricle patient. So what is abnormal? What is normal? so we do run the T1 mapping, but we don't really use that data much for changes in management of these patients.
Great, got it. Makes sense. And well, we have one question for Judith. She's Judith from Mexico. She wants to know if this classification from the 1, 2, 3, and 4, the last classification of the lymphatic anomalies, can be also used in a patient pre-Fontan, for example, a patient just with Glenn procedure.
Yeah, so that data, actually what I showed is pre-Fontan. So
Okay.
so if you're being true to the paper, you really should only be using that classification for pre-Fontan. But we're kind of expanding it now to post-Fontan. But that is for Glenn's or pre-Fontan patients. So it's stage 2 patients. That's correct.
And for Fontaine, there is still no classification about this.
Well, we've got, yeah, we've taken that class. I mean, that classification was, to be honest, we created that classification and then we applied it to the data and that's what we got. So, so you can, using it for post-Fontan, we don't know exactly what it means at this point. I showed some of that data that post-Fontan does have a difference. So yes, you can apply it to both, I think. But the stronger, until this next paper comes out, the stronger data is really is using it in pre-Fontan or the Glens. Does that make sense?
Yes, and I think that yes, makes sense, and also is for us it's very important to consider to evaluate the lymphatic and to do this MR lymphography. It's very important. So I think that it will be a topic for tomorrow. So we can talk about this tomorrow. Thank you so much, David. It was really nice to see you, and I'm very happy always to share your knowledge. You are a great radiologist, and it was a pleasure to have you here. Thank you.
Thank you. I'm glad I could participate. I'm happy to. Have a great afternoon for the next 2 talks.
Great afternoon.
I'm gonna sign off and listen. So.